Omata sensei.
So may I start tonight? I think this APASL webinar, I'm Dr. Omata from Tokyo. Maybe this is the one of the last sessions because seminar started in April. And this is maybe the last, but the biggest and the most important sessions because two speakers tonight, Dr. Llovet, and he is everyone knows about him, but I have to introduce him by saying he been in the hepatocellular carcinoma field for, I think he graduated medical school 1986, so it's almost, I must say, 34 years till now. And he published many papers, and H-index is about 80, I guess over 85, 86, and citations is over 40,000, 50,000. And then he was the most cited individuals in the years from 2014 to 26 by Reuters. And he is currently having a position at Mount Sinai as a full professor, but also in Spain. And I understand he is now in Spain, Barcelona, with a wife. And I think I'm really looking forward to hear his talk because physically we are not able to see each other. We really want to see each other, but unfortunately not. But because of the George Rao and Shiv-Sarin's accommodations, we are very lucky to have the Professor Llovet, so from Barcelona. Next lecture, please. Llovet, please. Joseph.
Yes, I'm trying to share the slides.
Okay. Can wait.
Can you see my slides?
Yes. Wonderful.
So, first of all, I mean, it's a pleasure for me to give this lecture for APASL and to be chaired by Masao Omata and by George Lau. I know them for a lot of years. I've been in Asia so many times, and it's a pleasure to give it from here, but I have to say it could be better next year to come to Asia. So I'm going to talk about target therapies in hepatocellular carcinoma. This is the outline of my presentation. We'll talk very briefly about epidemiology, molecular drivers, and then target therapies, first and second line immunotherapies, and the new era in combination therapies. So as you know, the liver cancer is the 6th most common cancer globally, the 4th leading cause of cancer-related mortality. Nowadays, we have 850,000 new cases, but by 2025, we are expecting around 1 million. And here you have the breakdown leading this East Asia close to 600,000 cases. In Europe, we have around 70,000. In the US this year, 42,000. So still liver cancer is A, the leading cause of death among cirrhotic patients, and B, the incidence of the disease is increasing globally. I would like to show this figure because it shows the mortality trends of patients in the US for 20 years, from 1990 to 2009. And as you can see, for most of solid tumors, there has been a significant decrease in the mortality trends, except for melanoma in males and liver and bile duct cancer in males and females looked at increase in males up to 60%. The main risk factors are well known. Hepatitis B virus accounts for 50% of the cases, hepatitis C virus, 30%. We have alcohol-related HCC, 15 to 20%. NASH is now one of the growing factors, particularly as a result of the epidemic and pandemic of obesity. I have to say in the US, 35% of the population is obese. And then we have cofactors, as you know, the most well-known is aflatoxin B1. Let's talk about a bit about drivers. This cartoon shows you the number of mutations of most of solid tumors. As you can see in the left-hand side, you have the highly mutated tumors, lung, melanoma mostly. In the right-hand side, you have the pediatric tumors, liquid tumors with less than 10 mutations per tumor. And in between, we have HCC with 50 to 60 mutations per tumor, but only around 8 of these mutations, 6, 8 are actually drivers. And which are those main drivers? Here you have a study we published with a group of Jessica Subman in 2015, and we identify in Western patients TERT as the most prominent mutation in 60% of the cases, beta-catenin followed by P53, ARID1, AXIN1. Unfortunately, all of these more prevalent drivers are undruggable mutations. Here you have a meta-analysis we ran with 1,000 cases. Only 25% of the patients at the very end have at least one druggable mutation in HCC, and this falls very short in the context of solid tumors. As you can see, thyroid, melanoma, glioma, they have 60, 70, 80% of the drivers that are targetable. In HCC, it's only 20, 25%, and so far, no single drug approved to block these oncogenes. Let's talk about first and second line standard of care. This is a summary of what the scientific community has accomplished for the last 20 years. Here you have the natural history for early HCC without treatment, 36 months, for intermediate HCC, 15, 16 months, and for advanced, 8 months. With resection, transplant, and local ablation, we are moving to 60-month median survival, with chemoembolization in the most recent trials between 26 and 30 months. And in advanced HCC, and I will expand on that, we're talking about a range between 10 and 17 month median survival. And of course, in red at the very end, at the very bottom, you have the unmet needs. Most importantly, we don't have a single adjuvant therapy after resection, local ablation. And also I have to say that TACE has been there as a standard of care for the last 15, 20 years. So we need to improve that. Well, you're familiar with sorafenib, that we published a study now in 2008, 12 years ago. We randomized the patients to sorafenib versus placebo. And as you can see, median survival was 10.7 for sorafenib, 7.9 for placebo, has a ratio of 0.69, and the trial was stopped. And this was a breakthrough in the management of the disease and the first systemic drug. As a result of that, it was approved by all guidelines as the front-line therapy. When we ran the meta-analysis of the Sharpened Asia-Pacific trial, we identified that two variables, what we call liver-only disease, this means patients without metastases, and hepatitis C virus infection, these are predictors of even better response with sorafenib. Here you have the median survival, 14 months for patients with hepatitis C. Conversely, this is the Gideon study in patients beyond Child-Pugh A, for instance, Child-Pugh B patients, and the study was able to gather more than 600 patients. Median survival was 5.2 months, Child C 2.6 months. So certainly this type of TKIs are not probably expanding survival in those types of patients. Well, let's see what happens after the SHARP trial. And here you have the list of trials that have been reported in phase 3. In green, only those that are positive, sorafenib, and then now atezolizumab, and I will explain that. And in second line, ramu, sirumab, regorafenib, and cabozantinib. And also in orange, sorafenib versus lenvatinib, because lenvatinib showed non-inferiority. Lenvatinib is a drug that is blocking BAGF1/3, FGF receptor 1/4, RET, and others. It's a multi-kinase inhibitor, and in this non-inferiority trial, the median survival was 13.6 months compared to 12.3 months. So, and the study hit the non-inferiority endpoint. So we can say that lenvatinib has similar efficacy to sorafenib. Interestingly enough, in the subgroup analysis, it seems that those patients with more aggressive tumors, FP more than 200, or those patients with macrovascular invasion seems to do slightly better with lenvatinib. The first drug approved in second line was regorafenib. So as you can see here, for the molecular structure, regorafenib is similar to sorafenib with fluorine. And in the trial, we include patients that first tolerate sorafenib and progress to sorafenib. It was a 2-to-1 randomization comparing rego versus placebo at that time point. There was no drug in second line. And again, regorafenib shows survival benefits, 10.6 month median survival versus 7.8 with a hazard ratio of 0.63. And as you can see, sorafenib benefit all the subgroup of patients, even with aggressive disease and regardless of etiology. In this study, the authors measure the median survival from the a starting point of receiving sorafenib upon they die with the sequence sorafenib regorafenib, 26 months, compared to the sequence sorafenib placebo, 19.2 months. And this gives us an idea of what can be expected with this type of sequencing approaches. Then we have cabozantinib. Cabozantinib is an appealing drug because it's blocking beyond BAGF is blocking MET signaling, and MET is very activated in advanced HCC, 50 to 60% of the patients. In this trial, cabozantinib again show survival benefits in second line, 10.2 months compared to placebo, 8 months. And again, in those patients with aggressive disease, extrahepatic or macrovascular invasion, and those with hepatitis B virus-related HCC, in the subgroup analysis, this is hypothesis generated, but nonetheless, it's informative, provide better outcomes. Then it comes to the point of ramucirumab. Ramucirumab is the only monoclonal antibody that is currently approved. It's a monoclonal antibody against VEGF receptor 2. In the first trial for all comers, the trial was negative, the REACH trial. In the subgroup analysis, though, they identified that patients with FP more than 400, there was a significant difference, and therefore the company decided to move forward with REACH2 that randomized patients to ramucirumab versus placebo only in second line, only if FP was more than 400 nanograms milliliter, and the trial was positive, as you can see here. And in the meta-analysis, considering both trials, so including more than 500 patients, median survival for ramu was 8.1, and for placebo 5 months, because here we're considering second line aggressive tumors, only the subpopulation of FP more than 400, that is around to 40 to 50% of the patients in second. Let's talk now about immunotherapy. You are very familiar with the compounds that are out there, particularly anti-PD-1 atezo, durvalumab, anti-PD-1 pembro, nivolumab, anti-CTLA-4, ipilimumab, tremelimumab. Here you have the landscape of the drugs and some of the approvals. Generally, these drugs lead to objective responses between 15 and 50%. In the checkmate of 40, in second line mostly, nivolumab as single agent show objective response in around 15% of the patients, but the outcome of these patients was outstanding, with median survival not reached and probably around 30 months, as opposed to 16 months for patients with a stable disease and 9 months for patients with progressive disease. Unfortunately, the classical biomarker, the PD-1, the PD-L1 immunostaining more than 1% of the cells was not able to discriminate responders. You can see objective response in those positive 26, in those negative 19%. Nonetheless, nivolumab moved to phase 3 head-to-head to sorafenib in frontline, checkmate 459, and the patients were randomized 1-to-1 nivo to sorafenib. Again, objective response with nivo was 15% compared to 7% with sorafenib, but the survival did not show statistically significant differences. You see the hazard ratio 0.85. I have to highlight, though, that this was the trial in which the outcome for frontliners was better of the ones reported at that time point, 16.4 months of median survival compared to 14.7 months. This is as a result of a combination of factors, efficacy of the drug, but on top of that, 50% of the patients were exposed to second-line therapies that have been shown to be efficacious. Another drug in second line, pembrolizumab, also a checkpoint inhibitor blocking PD-1, show that objective response was 18%. And here, despite that the median survival was 13.9 months, compared to 10.6 months in placebo, the pre-specified p-value for a significant trial was 0.017, and actual difference did not reach that pre-specified p-value. The difference was 0.02. So eventually we can say that this is the first trial in which we are seeing clinically significant benefits, let's say around 3-month difference, but it's not statistically positive, and therefore it's not incorporated in guidelines with the same status as those that are positive based on phase 3 data. So therefore, there is a need for biomarkers. The most used biomarkers are tumor mutational burden and PD-L1 expression. These are so far not working in HCC. We identified the immune class of HCC and reported that in 2017. 25% of the patients probably belong to what is called, they have inflamed tumors, and they have infiltrate of T cells, CD8 and activated CD8, cytolytic activity, signatures that capture cytolytic activity, and also signatures that capture response to checkpoint inhibitors in other indications. So one of the proposals is that these whole tumors are responders to single checkpoint inhibitors, whereas the others, particularly the ones with immune exclusion, might need combination of therapies because single agents will not suffice. And this comes the rationale for the combination therapies, and that is the dawn of a new era in HCC management. Again, the concept of hot tumors in which you have the infiltrate of immune cells, CD8, CD4, particularly T cells with granzyme B and others, or with expression of PD-L1. This will respond to checkpoint inhibitors. But then the majority of tumors are cold tumors with a non-immunogenic tumor microenvironment, and we need to switch that to get these tumors to be exposed to the surveillance by the immune system. And how we get that? Well, by using VEGF inhibitors, for instance. I'm listing here those that are approved in HCC. We're able to decrease Tregs, increase cytolytic activity of T cells, decrease TAM and M2 macrophages. Myeloid-derived suppressor cells also I'll decrease with these VEGF inhibitors, and increase dendritic cells and maturation of dendritic cells. And this may provide a switch for some cold tumors that suddenly are exposed to the immune system. The same has been described with TKIs, and in order to move from cold tumors that are oncogenic signaling mediated T cell excluded tumors, by blocking, in this case, CDK4, CDK6, Wnt signaling BRAF, particularly in melanoma, it has been shown that the tumors are able to switch to hot tumors with dendritic cell activation, T cell infiltration, and so on and so forth. So I'm going to show what has been reported in HCC. And here I'm showing the results of bevacizumab, atezolizumab, that this is the breakthrough of this year. Despite the pandemic, we have very exciting news. This was published in New England Journal of Medicine. The author randomized the patients in frontline 2-to-1 to receive the combination of atezo-bev compared to sorafenib with a primary endpoint of OS and also progression-free survival. And as you can see here, for the co-primary endpoint overall survival, the median overall survival was not reached by atezo-bev, but was 13.2 months by sorafenib, with an outstanding hazard ratio of 0.58 and p-value that lead to stopping the trial for efficacy. And as a result of that, this drug has been approved by regulatory agencies. So also in the co-primary progression-free survival, there were a substantial difference, 6.8 months for atezo-bev, 4.3 for sorafenib, a hazard ratio of 0.58. So it's also reinforcing the effect of this combination. A third piece of information is objective response, either by modified RECIST, 33% with atezo-bev compared to 13 with sorafenib, significant. Also by RECIST, the difference was statistically significant. And finally, and very unique in HCC, for the first time, these patient-reported outcomes, meaning time to quality of life deterioration, was significantly longer, 11.2 months for the combination atezo-bev compared to 3.6 months in sorafenib. So in summary, for based on phase 3 investigations, here I'm showing in frontline and second line the hazard ratios. Atezo-bev compared to sorafenib is superior. Nivo did not show superiority. Lenva showed non-inferiority and was approved based on the design of non-inferiority. As you can see, the upper boundary is not crossing the 1.08, and this granted non-inferiority approval. And in second line, Rego, Ramo, and Cavo are approved based on significant differences compared to placebo. I have to say also, and I'm showing here what we can see as the strategy nowadays, is that atezo-bev will be the front line and is already now being accepted as such. Although we don't know the percentage of patients that could be exposed to this combination because there is a percentage of patients that may either have autoimmune disease or any contraindications for the drug, or they have variceal, esophageal varices or gastric varices that has not been treated, and therefore this is a contraindication for bevacizumab. And in this instance, sorafenib and lenva still are frontline. Nonetheless, they will be used after atezo-bev upon progression, and certainly Rego, Cabo, and Ramo are other armamentarium that should be used in specific circumstances upon progression to the previous drugs. In the US, as I mentioned before, nivolumab, pembrolizumab, and now the combination nivo-EP are approved in second line based on phase 2 data. This is the first, one of the first consensus. This is an ASLD consensus conference that we have on trial design and endpoint, and we already are accepting in frontline atezo-bev, frontline and second line sorafenib, lenva, and then other therapies in further lines of treatment. So finally, just 1 minute to talk about ongoing combinations. One of the promising combinations is lenva pembro. Another one is a triplet, cabo, nivo, EP. Probably Professor Yao will comment on that. But regarding the lenva pembro phase 2 data in 100 patients, we have that with this combination, objective response rates achieve based on a central radiological review 46% of response and 88% of disease control rate. And this is a mark that is unprecedented in HCC almost 90% of the patients were controlled with this combination. Progression-free was 9.3 months, overall survival 22 months. That certainly looked competitive in frontline. And now the phase 3 LEAP-002 is already finished comparing this combination with Lemba alone, and let's see the final results. Another combination that has been reported is the Nivo-EP with several dosage. I'm just reporting here that the median survival for one of these combinations was very promising, 22.8 months. And I understand that now this combination has also been moved to phase 3. And if you check what is coming, certainly the combination therapies are the hot issue. So I would say that eventually the era of single agents in HCC eventually might be over. And now we know first in class, that is atezolizumab, but we don't know best in class, which will be the combination able to even overcome or be show superiority to atezolizumab. Here I'm listing some of the most striking combinations currently ongoing. And just to give you a final shot, these combinations are not now currently being tested only in advance, but combinations and immunotherapy are plugging all the stages of the disease. So after resection and local ablation, we have at least these 4 trials: Nivo placebo, Pembro placebo, atezolizumab versus placebo, Durva-bev versus placebo. In intermediate, as a standard of care, TACE, and we have also TACE combined with these combos, Beva-Durva, Lemba-Pembro, Nivo-EP, or even head-to-head comparison, Rego-Nivo versus TACE. And in advance, as I mentioned, we have Lemba-Pembro, Atezo-Cabo, Nivo-EP, Durva-Treme, and also Carmelinumab and Apatinib. So in conclusions, Mr. Chairman, epidemiology, the incidence is growing and will still be growing despite the effectiveness of antiviral therapies against hepatitis C virus. So it's expected by 2025 to reach 1 million. 25% of HCCs have at least one actionable mutation, but still now we have not been able to prove that any given drug is able to improve survival in these niches of patients. For all comers, atezolizumab now has shown superiority and is the front line. Sorafenib and Lemba can also be considered front line for those patients with contraindications for the atezolizumab, or second line, and then Rego, Cabo, and Ramo are accepted by guidelines based on phase 3 data. And FDA has approved a Nivo, Pembro, and Nivo-EP based on phase 2 data. And mostly the emerging combinations are combining TKIs or monoclonal antibodies with checkpoint inhibitors, and now are not only targeting advanced HCC, but also adjuvant and intermediate. And with this, I want to end. Thank the organizers for inviting me, and hope to see you face-to-face next year. Thank you.
Mentioned that comparing to the other lung cancers or other solid tumors, we don't have a druggable mutation, unfortunately, but instead we have some combinations. So it's more or less a competition of companies. So what the investigator do for this field? Because drugs competition is pretty good, but we are simply involved with these programs. So what do we do?
So there are 2 strategies. Well, first of all, you have to have some saying with the companies, and sometimes this is very difficult. But there are 2 strategies to impact our research in improving the targeting of some of what you were saying, some of the drivers that are out there that we don't have drugs for these oncogenic addiction groups. One is to identify pretty well. For instance, we did that with FGF19. That is a known oncogene in HCC, overexpressed in 20% of the patients. And then there was a specific drug and was published in Cancer Discovery, the trial, in which we were analyzing in patients with immunostaining positive for FGF19 COVID-19, and we were giving the FGF receptor 4, and objective response was 16% compared to 0 in those with immunostaining negative. The problem is, okay, how this is competing with these combinations that for all comers are giving 33% objective response or even beyond that is something that we need to elaborate upon. And the second thing is, well, let's assume that we have single drugs or even combinations, but even, for instance, let's jump to Atezo-Bev, that is the hot data. So you have 35% of the patients achieving objective response. Probably those patients with the stable disease might benefit, but not as importantly as those who achieve an objective response. But we don't know which are the responders. So the second approach will be to identify the biomarkers that predict response. The problem is that the speed in which the results are moving is so high that, for instance, now we already have data on the responders to single agent, and probably we will publish that in 2021, but already we need now biomarkers for the combination. So I would say that let's say the pace of the trials are very fast, and then the academia and the research sometimes is chasing this pace.
You know, I'm in the position of looking all the aspects.
If I may ask, Josep, I have two brief questions, and these are both live patients. One is a post-transplant 69-year-old man, and he has a recurrence, and I was giving him lenvatinib. He is unable to tolerate. Sorafenib, he is unable to tolerate. And he has a lesion which is about 3 centimeters, and his AFP is rising. It is 53 now. So he had once a microwave, and now he has a recurrence. So that is one patient, and what drug if he is not tolerating both?
Yes, so the concept with the post-transplant is that in principle, checkpoint inhibitors are not indicated for the risk of rejection. And as a result of that, I will, in this case, try either ramucirumab or cabozantinib if it is possible in your area. This will be my first approach. The second, certainly, you can include the patient in trials, but generally the trials are excluding patients with transplant.
Yes, this is, we have asked for cabozantinib. One more, Masao. The second question is very important. He is an orthopedic surgeon who had a large HCC. He responded amazingly with nivolumab and lenvatinib, but his AFP came down, and now it has gone up. So the question is, once the person after, let's say, 10, 12 doses becomes, let's say, resistant to nivolumab, PD-1, do you add bevacizumab, or there is no data of nivolumab with bevacizumab? So
yeah, you are right. So now the problem is that after frontline combination with, let's say, TKIs or monoclonal antibodies with checkpoint inhibitors, we don't have any data. For instance, the question is, what is the data supporting any combination after Atezo-Bev? And we don't have data. But theoretically, the patients that are responding to nivo plus lemba might not be in all instances resistant in case they progress to other combinations. So this needs to be proven because the mechanism of exposing the tumor to the immune system might be different. The mechanism with lemba mostly is driven by decrease of Tregs, whereas, for instance, the mechanism of cabozantinib has been reported to be mostly mediated, among other things, not only by T-cell immunity, but also by innate immunity with attraction of neutrophils. So theoretically, it's not that because you are exposing a patient in frontline to checkpoint inhibitor, then the patient cannot receive this treatment anymore. As long as you give it in combination, I think that it's fair to say that you can have another shot with another combination.
Okay, good. Llovet, thank you very much. George Lau is waiting. So, George.
Yeah. Well, this is an excellent talk, and I'm sure the audience will be very delighted to hear the state-of-the-art lecture. Our next speaker is Dr. Thomas Yao. Thomas is my colleague at Primary Hospital, and I know him since he was a student. And that makes me think that he is always young. In fact, life carries on, and he is now a very grown up and very experienced expertise, well known for his work in hepatocellular carcinoma. And without undue delay, I would like Professor Thomas Yao, to give a few real case of how hepatocellular carcinomas was being treated, and what he think would be the steps we can move forward along this line. Professor Yao. Yes, Thomas, are you with us?
So, can you hear me?
Yes,
No.
Thomas.
Okay.
Now.
So first, I have to thank APASL for inviting me to this important symposium, especially George, to give me a chance to talk about the real-life management of HCC patient, also our perspective in how to move forward. So this is my disclosure. So to start with, I just present you an interesting case. A 64-year-old male, the patient have alcoholic cirrhosis. Back in 2009, the patient was not infected with HBV nor HCV. And then the patient have underlying NASH, fatty liver, chronic pancreatitis, and also DM hypertension. The patient initially have a screening ultrasound done in February 2017, so only fatty change, no lesion. However, his alpha fetoprotein actually rising quite quickly from 9 and then to 150 in 3 months' time. So subsequently, we booked a CT scan. And at that time, the patient has also falsely deranged liver function with the ALT, with a rise in ALT, AST, and bilirubin around 38. However, and now still normal. A bit of thrombocytopenia, so we booked the CT scan. We show the patient actually have a 5.8 centimeter hepatocellular carcinoma. So and then subsequently we go to book the PET CT here in Hong Kong. We actually not only do the FDG PET, we also do the C-acetate PET. So it is a dual tracer PET. So dual tracer PET at that time only showed the patient have a localized disease. As you can see the uptake here. So obviously the patient was referred to the surgeon for consideration of surgical or resection. Unfortunately, intraoperatively, we find the patient have a multiple peritoneal metastasis with a lymph node biopsy. So the patient indeed have poorly differentiated liver cancer. Due to the disseminated disease, the patient have an open and cold surgery. And then the patient subsequently referred to us. So we explain various options to the patient. As we are leading the global LEVO-EP trial that time, we actually just offer the patient LEVO-EP outside clinical trial. The patient have a first dose of LEVO-EP in October 2017, and the patient only complained of just very mild malaise and then have some loss of appetite. And then the patient have a 6 cycle of LEVO-EP. One of the important side effects is hypoadrenalism. We detect, and then we just put the patient on hydrocortisone replacement. So this is the alpha fetoprotein level of the patient. So you can see when we start the LEVO-EP in October, the AFP coming up quite impressively, and then come down to around 2 or 3. So this is the PET scan of the patient. So the right side is the PET scan of the patient before at the time of surgery. So and then the left side is the patient after 4 cycles of LEVO-EP. So you can see the caudate lobe of the tumor actually have shrunk a lot. So this case is just the patient is now still in complete remission after almost 3 years of treatment. So this is just to show you one of the current trend in the immunotherapy of liver cancer is the combination of the anti-CTLA-4 and also the use of the anti-PD-1. So the site of action of the anti-PD-1 is usually in the tumor microenvironment, and we release the break of the tumor cell or the antigen presenting cell on the T cell. However, CTLA-4, actually the site of action is actually in the lymphoid agitating organ. In the adult patient is in the lymph node. It actually relieves the inhibition of the dendritic cell on the T cell, and it will subsequently lead to more mature and also increased number of T cells going to the tumor microenvironment, and it works with the anti-PD-1. So this study will be just published recently in JAMA about the use of the Levo-EP in patients with advanced hepatocellular carcinoma. As Joseph has elaborated, it is a phase 1/2 3-arm study. In arm A, we use the high-dose EP plus Levo. Arm B, we use the no-dose EP plus Levo. And arm C, we actually, interestingly, we use continuously EP Levo. And then the study endpoint were safety and tolerability. So if you just look at the response rate, you can see for the arm A patient, which we use the high-dose EP, you can see a lot of patients actually have a significant tumor shrinkage, and we have around 6% of patients actually achieve complete radiological remission. And then even the patient who actually have a tumor progression, they only have slight tumor progression compared to the arm B patient, which we use the no-dose EP, and arm C patient, we use the continuous Levo-EP. So if you look at the overall survival for the Levo-EP patient, so if the patient has some tumor shrinkage by RECIST criteria, you can see if the patient can achieve complete response or partial response. Basically, this kind of patient, they don't die. And then we now have the 4 years follow-up data. And we still have around nearly half of the patients still survive after 4 years of follow-up. Remember, this is a second-line study. All the patients are refractory to sorafenib. So even the patient who actually have a stable disease with Ipi-Nivo, in second line, the OS was still around 14.5 months. For the PD patient, was around 8 months. So the current study is going on, CheckMate 90W, but we actually conduct this study in the front line. We are comparing the Levo-EP versus physician choice of TKI, sorafenib or nivolumab. With the primary endpoint OS. So I think this clinical trial is currently almost halfway. So I hope we can hear the result of this trial in 2 years' time. And then lastly, what do you think will be the future treatment of advanced hepatocellular carcinoma? So if you look at all the ongoing clinical trials here, you can see we actually have a lot of clinical trials going on. Majority of the clinical trial is use the cancer immunotherapy plus TKI, or the use of the 2 immunotherapy together. Any more aggressive therapy? So we actually present this interesting triplet therapy in GISCO this year. We use Levo-EP double IO plus TKI cabozantinib in patients with advanced hepatocellular carcinoma. So it is again a phase 1/2 study. We randomized half of the patients to receive the doublet Levo plus cabozantinib, and other half of the patient will receive the triplet, the Levo-EP plus cabozantinib. So we just show you the waterfall curve here. If you look at the doublet, it's quite similar to the pembrolizumab, and then for a lot of patients have a significant tumor shrinkage. However, if you look at the triplet, you can see almost 90% of the patients have some degree of tumor shrinkage. Even for the patients who actually have progression, they only have slight tumor progression. And lastly, in the future, I think we should, for future immunotherapy treatment in HCC, apart from using anti-CTLA-4 and anti-PD-1, we are going to move away from this target. We also explore other targets. So like this LAG-3, anti-LAG-3, which is currently explored in melanoma, in Queen Hospital, we are going to start this clinical trial probably in a few months' time. And also, apart from the anti-LAG-3, we have another clinical trial currently ongoing is another T-cell agonist, TLR7 agonist in oncology. So there are, apart from the anti-PD-1, anti-CTLA-4, there are still a lot of checkpoint inhibitor or other T-cell agonists. Hopefully, we may see some CAR T-cell therapy in patients with liver cancer in the future. Thank you.
Thank you very much, Thomas. This is a very nice case presentation. So with lots of work being done at primary hospitals with your team. I think that, well, so we are just on time, and there is a questions from the Masao, and it's about combinations of TKIs and immune checkpoint therapy to expose tumor antigens to ICI. But what is the questions? This is not the questions by itself. But anyway, I just want to ask both of you about hepatocellular carcinoma, because we know it's a more heterogeneous disease, and well, we have seen different nodules, different HCCs in the same livers to bear the different mutations. And we also have different etiologies, which brings along the hepatocellular carcinoma. And with all the trial designed, and whether you have any well, chance to look into the other factors which affects the response in that sense. For instance, hepatocellular carcinoma due to hepatitis B, and whether the viral suppression is adequate, or those with the hepatitis C post-SVRs, and how were they being treated? And are these factors being considered during the treatments of hepatocellular carcinoma?
Well, I have to say that currently in the trials, all patients with hepatitis B virus need to be on drug suppression. So the virus need to be suppressed, otherwise they are not getting into the trial. And now more and more in the West, the patients sometimes are FC with sustained virological response. And certainly we don't know in this group of patients if we are doing better or not once the HCC is established. But certainly with the current treatments, the patients that now are getting into some of these studies or even actual treatments have sustained virological response. You were talking about etiology and potential impact on responses. What we know for sure is that in sorafenib FC patients are doing better. And with checkpoint inhibitors, I think it needs to be confirmed, but this has been a trend that may work better in viral related etiologies than in non-viral, but it is something that needs to be confirmed.
So I think one of the problem in HCC clinical trial design is we have two heterogeneous populations. So maybe in the future, if we have so many compounds, maybe we have to, but we haven't got any biomarker. Maybe we have to be conduct the clinical trial in a biomarker-driven design, just like the lung cancer or colorectal cancer. Another thing is that nowadays we are assessing all the response of the immunotherapy based on like all this progression-free survival, RECIST 1.1. We actually don't know whether this kind of measure are the best measure for the efficacy in immunotherapy. You know, all this progression-free survival, all this response rate, they are more applied to chemotherapy era. However, the mechanism of immunotherapy is quite different from chemotherapy. It may not give rise to immediate tumor shrinkage. However, it may translate into long-term survival. So I think for the HCC childless, they should think about the future, okay, endpoint in assessing all the immunotherapy. We may have to move away in using all the endpoint like the OS, PFS, because they may not reflect the true value of immunotherapy. Yeah.
Well, I have a comment here. I mean,
Interesting.
Say it again.
Yes, Joseph. Yes, please comment.
Oh, just to mention that we ran this meta-analysis with systematic review, including now 27 frontline and second-line trials to assess the correlation between progression-free and OS, because in some cases there is a positive trial with progression-free and not OS. And the conclusion, the bottom line is that if you have an outstanding difference, and we established the hazard ratio of 0.6, means that the difference between the two arms is so striking, it always leads to OS survival differences. Okay. Conversely, if you have a weaker, let's say, it's significant difference in progression-free, but the hazard ratio is 0.8, well, you wait for survival. And this more and more might be useful because more and more second-line therapies are there. And George, there is a question from Massimo about chemotherapy. Massimo, I think that the field is not moving in this direction. We are not sure if chemotherapy will be useful to release new antigens and enhance the visibility of the tumors, but I would say that we're more moving into the triplets, for instance, the ones that Thomas was presenting, I would say.
Some people have presented their result of, if people from China, they have presented their result using anti-PD-1 plus chemotherapy, but basically the result was quite similar to the use of single agent immunotherapy. Good, yes, but it's a small trial, I have to say.
Well, there is questions from the floor, and the question is whether it is possible to identify the inflammatory nature of the tumors based on radiological studies or imaging.
Well, I think that this radiogenomics that is very popular. I think that still we don't have the proper study. There was some radiogenomics to link molecular classes to radiological behavior. For instance, with those with very fast uptake of the tumors were correlated with the proliferative classes. But in terms of behavior related to the immune class, differentiating hot tumors and cold tumors, I think that there is no thorough study to my knowledge.
Hello, Omata from Tokyo. Yes, wonderful talks, both of you. I enjoy very much. I'm now in the position to oversee all the oncologies. And as you mentioned, the lung cancer among the solid tumors is the leaders because they have the druggable mutation along with the IO combinations. And in fact, you go to the ASCO, 5,000 papers published, and there may be 500 on lung cancers. So we are following the lines for the solid tumors, lung cancer in particular, especially we don't have a druggable mutations. So nowadays, as you mentioned, the future is whether it's a combination of IO, or the combination of IO and TKI, or the combination of IO and the cytotoxic drugs. For example, lung cancers, they are using the 4 cycles of cytotoxic drugs to prevent the immediate drops right after the treatment start. So maybe those combinations, and then looks like mostly depend on the companies. Like some company use the IO, and some company using the IO plus cytotoxic drugs. So we are in the middle of the companies' competitions. So again, I repeat, what the investigators do by yourself, maybe something about in the advisory board committees, but I think all the things are decided by the companies. So what do you do?
Yes. So, well, I think that this goes along the lines of we mentioned before. One of the areas of research is to identify biomarkers of response, but this has been very tough. For instance, for checkpoint inhibitors, I think FDA has approved tumor mutational burden and anti-PD-1 immunostaining as a companion diagnostics for pembro and lung cancer, and nothing more. So the problem is that in order to get, one thing is to get a good study, and the other thing is to get very, very, very robust data to be adopted by guidelines, and afterwards to be adopted by regulatory. And this is very difficult, but certainly I think that one area is to identify biomarkers. Again, for instance, for atezolizumab, we are thinking about 35% of detected response. So certainly would be priceless to identify the responders, and with the others, let's see what we're doing, right? Because the cost effectiveness of this treatment will be much more appreciated. Another thing, but for instance, I have pursued this a lot, is that the oncogenic addiction looks, but I think, look, so you have been working with liver cancer, right? So the landscape of mutations of cholangio by chance is different. And then cholangio has 60% of druggable mutations. And then 25% of the patients with intrahepatic cholangio have FGFR receptor 2 fusions. And already pemigatinib is already approved. And now is this phase 3 head-to-head to GemCs. And this is because by chance this drug has this oncogenic addiction loop. Also, IDH1 mutations, 15%. The drug already was approved by FDA based on progression-free survival, but anyhow, this can be done. In HCC, as I mentioned, we have the FGF19 overexpression, 20% of the patients. Phase 2 data was okay in terms of objective response, but nothing is spectacular. It's not that we're getting 60, 70% objective responses. And then, of course, you have amplification of VEGF-A, 8% of the cases. So it's very difficult with this, right? And needless to say, with the mutation, of course, if you are saying, okay, what could be your bet for single agent? Well, if you get a very, very good CTNMB1 Win inhibitor that is blocking CTNMB1 mutations, this accounts for 25% of HCCs and 70% of hepatoblastomas, and still is undruggable. This is an avenue in HCC, but the companies are claiming that they have CTNMB1 inhibitors for 15 years, and I haven't seen anyone flying in phase 2. That's a problem. So we need CTNMB1, of course, MYC. MYC is amplifying 15% of the cases, but we don't have anything. And TERT, the same.
We are about to finish, and then maybe looks like Professor Thomas, you want to say something about. So please, in short, in summary.
I just think, okay, even for a single agent, okay, it's quite difficult to find biomarker. But in if you use combination, honestly, I think it's quite unrealistic. We can find a biomarker which can predict the response to both agents. But you know, Professor Omata is quite correct. Okay, a lot of HCC drug development is dominated by the drug company because they all have all the new market, they have all the new drugs, and they have all the money to run the clinical trial. But as a medical oncologist doing a lot of clinical trial, we actually have a lot of intellectual input into this clinical trial. Drug company, they have the money and they have the drug, but they may not know what's the best way to do the clinical trial, which group of population, and whether the this kind of clinical trial is feasible. So as an academic, we still work with the drug company, provide all the intellectual inference. Yeah.
Well, in that context, I may finalize that this vaccine by Moderna and the Pfizer's, it's a wonderful one because they put the messenger RNAs into your cell, into your host, and making the proteins targets. I think this is exciting, not just for the COVID-19's preventions, but in the medical science, this can be the victory. So it can be utilized in the oncology. I think
Actually, you know, Moderna is actually, they are, before the COVID, they are making the vaccine, the cancer vaccine, actually.
Tumor vaccine.
Yeah, they are actually start with making the cancer vaccine. They just report some promising data in ESMO 2 months ago about the cancer vaccine. Yeah.
then that case, that's your field. I mean, we are not under the companies. We are the principals, you know, to do thing. So I enjoy very much inflammatory cancers. I enjoy Llovet. Yeah, your ideas, very good, wonderful. And then Dr. Yo, long term, you may work until age 100 years old.
Well, Llovet get younger. He is having regression.
Tell my wife again.
So,
Okay, all right.
COVID-19, yes.
Hey,
Okay.
So
Bye-bye.
Professor Sarin wants to make the final comments since you are here. Professor Sarin? If not, then we would like to close the sessions. And thanks for the wonderful input and the intellectual interactions with all of you.
Hong
Good luck to everybody.
Kong,
Thank you.
yes.
Okay, see you. So much.
Turkey, Hasmik, bye-bye.
Bye-bye.
Hi.
Thank you very much.